It's my pleasure to introduce Dr. Tutberg, who is the Chief of Heart Failure Transplant and Mechanical Circulatory Support, thank you, at Stanford. His research interests are in clinical outcomes in patients after transplant, and as well as novel approaches to immunosuppression. He has participated in many single center and multi-institutional research studies and published widely in the field of transplant and mechanical support. He served as president of the International Society of Heart Transplant and Lung Transplantation, and he will highlight the role of cardiac rehab in MCS. And Elizabeth Flores is a nurse practitioner in the adult heart transplant and MCS program. She's an assistant clinical professor and volunteer faculty at UCSF in the Department of Physiological Nursing. And her areas of professional interest is in prevention of sudden cardiac death and in heart failure patients. And Ms. Flores Burns will highlight the cardiac rehab approach to advanced heart failure and heart transplant patients. Is Dr. Tutberg going first, I think?
I think Lizbeth is going first.
Okay, Liz, please.
Can you hear me okay?
I don't think.
I should be on.
I can hear you, Liz.
Okay, fantastic. So let me just get the slides. I am trying to get me out of here. Sorry. Are you able to see my slides?
Yes.
Okay. So see if I can get them to expand here. Sorry. Oh, right here. Okay. Great. So thank you for the kind introductions. An honor to be here and follow the great faculty. I will be discussing with you cardiac rehab in the advanced heart failure, specifically heart transplant. So I have no disclosures related to this presentation. Our learning objectives in 15 minutes, we are tasked to define heart failure and advanced heart failure, list the classification stages of heart failure, we'll review the treatment options of advanced heart failure, and describe strategies for implementing cardiac rehab in the heart transplant patient. So the basic definition of heart failure is either an acute or chronic progressive weakening of the heart muscle, thereby impeding its ability to pump and reducing the blood flow to vital organs. The symptoms can include fatigue, shortness of breath, lower extremity edema, lack of appetite, and there are some GI symptoms like abdominal bloating that can be seen. There's also poor exercise tolerance. We think of heart failure as diastolic and systolic. With diastolic, the heart has difficulty filling due to stiffness, and systolic heart failure is just boggy and it's unable to pump adequately. So advanced heart failure is the continued and progressive damage of the heart and its symptoms. Despite the guideline-directed medical therapy. Even with optimal medical management, medications can be less effective. Sorry, I'm being texted here.
Yeah, Elizabeth, it's hard to hear you with the closed captioning on. Would you mind turning that off? Thank you.
So let me see how I do that. Jesse, are you able to jump in and help me turn this off?
I can share my screen, your slides. Just tell me next slide, okay?
Okay, let me just see if this one. Oh, maybe here. I think I just did that.
Do you want me to turn it back? Go ahead and share your screen again. Yeah.
Yes.
You want me to share? Okay, you want me to share? Yes, okay.
Okay, what happened to my slides? Do I need to go back? Can advance. Am I able to advance? Okay, here. Sorry, a little bit of a distraction there. So the Heart Failure Association first defined this concept in 2007 and updated in 2018. The updated version emphasizes the role of comorbidities such as tachyarrhythmias and heart failure with reserved ejection fraction. I'm mainly discussing heart failure with reduced ejection fraction with our research lays. So clinicians play an important role in identifying these groups early enough to intervene. And those patients that have advanced heart failure and wish to prolong survival should definitely be referred to a specialized heart failure team. So some of the recommendations can include advanced heart failure treatment, whether it's pharmacological or non-pharmacological. And depending on the stage of the disease and the goals of care, palliative care. So heart failure is associated with a high risk of morbidity and mortality. It remains still a significant public health problem. The American Heart Association reported in 2021 that the incidence of heart failure would be approximately 6 million or 1.8% of the total US population. In 2018, heart failure was mentioned 379,800 death certificates, which is about 13.4%. This disease is typically in older populations around ages 65 to 70. So we classified heart failure in several stages. New York Heart Functional Association class, I think most people are familiar with this. Then we have the American College of Cardiology and the American Heart Association class. And then the Heart Failure Association has a specific criteria for advanced heart failure. So the New York Heart Functional Association class with class 1, the individual basically has no symptoms with normal physical activity. Class 2, there are mild symptoms with normal physical activity. Class 3, there's marked limitations with less than ordinary activity. The patient will have heart failure symptoms. Class 4, the individual is unable to do any physical activity without discomfort, and they typically have symptoms at rest. The ACC and AHA heart failure class is A through D, and A, they are at risk for heart failure, but they do not have structural heart disease. Class B, they have structural heart disease, but without signs or symptoms. Class C, they have structural heart disease with prior or current symptoms. In Class D, they have refractory heart failure requiring specialized interventions, and these are the patients that we'll be discussing here. So some treatment options for advanced heart failure. So this goes beyond medical therapy. Typically class 2 or 4, most of the patients, we like to think that they're on maximal guideline directed medical therapy. As the disease advances, they become advanced heart failure, they can be on IV inotropes, which are medicines that can change the heart contraction, plus or minus GTMT, depending on tolerance of the medications. There's the option of mechanical circulatory support that can be temporary, such as Impella via ECMO and intra-aortic balloon pump. And then the durable left ventricular assist device, LVAD, which is a pump that can be used for end stages of heart failure. And this is when GTMT or inotropes are no longer providing relief. So some of the mechanical support, dural mechanical support that Dr. Tutterberg will be discussing, just to get familiar, are displayed here. So we clearly can't talk about heart transplant without mentioning a little bit of history. The first successful heart transplant was performed by Dr. Christian Bernard in 12/3/1967. And then Dr. Norman Shumway performed the second successful heart transplant in 1/6/1968 at Stanford. So just switching gears, sorry about that interruption. Cardiac rehab. So we all heard this morning, guidelines definitely recommend that heart failure patients should exercise. There are some gaps in the evidence. Some of the trials have enrolled patients with stable chronic heart failure or stabilized GTMT. So the feasibility and safety of exercise training in early post-op patient is unclear. There are some studies, but they are small. We also heard the phases of cardiac rehab, so I won't spend too much time on this. The phase that I typically see patients is phase 1. And just on our population, a lot of these patients have to postpone or delay phase 2 and 3 based on their deconditioning. So since our patients have had chronic heart failure or chronic deconditioning, after phase 1, they can be referred to an acute rehab, which they may stay 2 to 4 weeks, and then at some point can enroll in cardiac rehab. There's home health physical therapy that a lot of my population has. And then depending how severe the deconditioning is, they can go to a long-term facility. So for heart failure stages C exercise in relationship to cardiac rehab, it is recommended for all the patients who are able to exercise, do it and to improve exercise capacity, quality of life, and reduce heart failure hospitalization. This is a class 1A, level of evidence A. And also supervised exercise-based cardiac rehab programs should be considered in patients with more severe disease, frailty or comorbidities, which have a lot of my population. So this is a class 2A, level of evidence C. And I know we discussed the benefits of cardiac rehab, such as this slide, I think, said it all, and the benefits that we're looking for our heart failure patients. Exercise can increase cardiac output, thereby decreasing the filling pressures, decreasing the resting heart rate. It improves both the sympathetic and vagal tone, and reduces the hormones renin, angiotensin, and aldosterone that we know can be detrimental if it continues to the heart. It decreases inflammation and inflammatory cytokines. It decreases insulin resistance, adiposity, and hyperlipidemia. It improves muscle fiber, it improves oxygen extraction, strength, and decreases sarcopenia. It also improves endothelial function by decreasing vasoconstriction, decreasing left ventricular afterload, and hypertension. Also, the respiratory muscles, they regain strength, and the minute ventilation increases and the dyspnea decreases. So approaching the heart transplant patient, there are some key points to keep in mind. First off, the exercise tolerance needs to be established. Patients that are transplanted have denervated hearts. This can lead to chronotropic incompetence. Some of these patients require medications to keep the heart rate at a certain level for adequate cardiac output, such as albuterol or theophylline. So this can become a barrier or a challenge for exercise. Also, we talked about earlier the nutritional status. Some of these patients may come with cardiac cachexia. Yes, they get artificial nutrition, but this is an ongoing process that takes time. And are there comorbidities, diabetes, peripheral vascular disease? Are they controlled? Will this be barriers to exercise instead of the heart rate or the pulmonary status? And sternal stability is also important. Now, sternal precautions, most patients follow 3 months. It's important to remember there's really no significant research regarding the length of time that the sternum takes to heal. A Stanford would recommend 3 months. Also, it's important to detect any movement of the sternum. If that's the case, then they need to be referred back to the referring clinician. So we see exercise has been shown to improve reinnervation and autonomic control. And it's important to have a comprehensive approach for these patients. Are they ready for teaching? Do they need psychological support? And all the strategies need to be aimed at reducing cardiovascular risk factors. So other tips to remember, since the heart rate may not be a reliable marker of effort due to the denervation, some tools that can be helpful are VO2 peak and the Borg scale. I think a lot of people are familiar with this. Also, anxiety and detecting this as a potential barrier in regards to the sternal precautions. There's a lot of fear of pain with movement, and they just need to get past that. So the Borg scale developed by Dr. Borg is a rating of perceived exertion, and it goes from 6 to 11. The perception is that it's very light. 12 to 16 is somewhat hard, and 17 to 20 is very hard. The VO2 peak provides the amount of oxygen uptake and also the CO2 production plus the minute ventilation, then you come up with a VO2 peak. This is the gold standard measure of respiratory fitness and reliable predictor of survival of chronic heart failure. Interestingly enough, there's a strong linear correlation with cardiac output and skeletal muscle blood flow with VO2 peak. This slide displays the impaired hemodynamics of the heart failure patients when compared to normal patients. If you look on the right-hand side on the y-axis, we have the tissue uptake, the flow, and on the bottom we have the peak VO2. So the heart failure patients achieve their peak VO2, but you've noticed that the tissue uptake is much lower when compared to normal. And on the right-hand side, we have the graph with the y-axis is the cardiac output and VO2 on the x-axis. Again, the heart failure patients have a much lower cardiac output and VO2. So this is one of the reasons that they have a lot of symptoms. So in summary, cardiac rehab is safe in heart failure patients. Heart transplant patients can have exercise intolerance due to deconditioning or chronotropic incompetence. Establishing a baseline intolerance can be helpful to break down any potential barriers. Establishing exercise baseline, sorry, we just discussed that. Hearing someone breathe there. The nutritional status and emotional readiness to engage in exercise training is also important. The Bohr scale is an alternative tool to determine capacity when the heart rate is not reliable. This is practical, well-validated, and fairly easy to use. VO2 peak can also be useful in guiding exercise training. Thank you for your attention, and I provided some references as well. Jesse?
I think Dr. Tutberg is going to share his slides next.
Great, thanks, Liz. Let me see if I can share my screen here. Can you guys turn over the control so I can share my screen? Still saying my screen sharing is paused.
Jesse or Mario, can you give access?
Let me try again.
Yeah, try again. Otherwise, I can see if I can do it.
Can you see it now?
Yes, I can.
All right, sorry. It was at the end of the slide, so let me go back to the beginning. So thanks again for being invited to be part of this presentation. So I'm going to talk a little bit about mechanical circulatory support and cardiac rehab. Sort of, I don't want to steal the ending, but there's not a whole lot we know about mechanical circulatory support and cardiac rehab, but there is some signal that it is beneficial, but I think there's still lots to learn. So by way of my disclosures, these are my disclosures. I do have some relationships with the current VAG companies, but they don't affect today's presentation in any way whatsoever. So these are the current generations of VADs. Liz showed you a couple of pictures. So there's the HeartMate 2, the HVAD, and the HeartMate 3. And all these devices are approved for short-term support, typically intended for people who are waiting for transplantation. They're getting too sick for a heart to become available, so they get a pump and they rehab them on the pump, and then they get transplanted and rehab them after their cardiac transplantation. And then there's another form of support that's for patients who have heart failure that's just as bad as people who require heart transplantation, but they're not heart transplant candidates, typically because of a combination of age and other comorbidities. And that's what we sort of call destination therapy, or long-term support as it's more commonly called now. Over the course of the past couple of years, there's been a change in what's out there. With the introduction of the HeartMate 3, it's clearly superior to the HeartMate 2, so those devices aren't really being implanted anymore. And the HVAD was recently withdrawn from the market, probably about a year and a half ago. So the only kind of game in town now is the HeartMate 3, but it's a very good and sort of the latest generation of these pumps. So many of you may not be familiar with the way the pumps work, so just a basic overview. The LVAD itself is placed in the apex of the left ventricle, as you can see on the picture on the right-hand side there. It's connected to the outside through something called a drive line, which is a cable that goes through the skin, typically in the right upper quadrant. It then connects to something called the controller, which is sort of the brains of the operation, and allows the patients to see some alarms and have a little bit of control. But basically, these devices are set at a certain speed and left at a certain speed, and I'll talk about that and the implications for cardiac rehab in a second. And then lastly, that controller is hooked up to a couple of batteries that allow the patient to walk around for up to 12 hours without having to either plug into a wall or recharge their batteries. So this is the way the HeartMate 3 looks on a stop, because it's a little bit jumpy. But on the top here is where the blood comes in from the left ventricular apex. There's only one thing that's moving in the whole device, and it's suspended magnetically and turned magnetically, so there's no mechanical wear. It just sort of sits inside that blood pool and spins continuously with the HeartMate 3 at a rate of about 5,000 RPMs. And then the blood is sort of accelerated out to the sides of the pump and then ejected through a graft, which is attached to the ascending aorta just above the aortic valve. One of the things that also is unique about these sorts of pumps is that it's continuously pumping blood rather than your native heart, which fills and then empties. And so you have a very minimally detectable pulse, and it's difficult to get a blood pressure with something other than a Doppler. So as you're exercising these patients, you really can't feel their pulse, and you require sort of somewhat specialized equipment to measure their blood pressure. So why are we talking about this? So if you look at sort of the number of implants of these devices in the US, and this is data from Intermax, which is a large national database of all approved devices. So this is a pretty good reflection of what's being implanted in the US. You can see that over the course of the past 5 or 6 years, anywhere from 2,500 to 3,000 implants per year, which is as many or more than the number of heart transplants we're doing. So you're just as likely to get referred somebody with an LVAD as with a heart transplant. So they're reasonably common. And when you look at why these devices are being put in, you can see the green bars here represent destination therapy. So about 80% of the patients that are being implanted with these devices, they're being implanted as their long-term therapy. So this is their alternative to heart transplantation. They live for many years, sometimes up to 10 years with these devices. So these are parts of these patients' kind of lifestyles, and there's more and more patients being supported for longer and longer periods of time. So how do they feel just in general? If you look at the sort of most recent trials and you look at the patients going into the trial, they obviously all feel pretty bad. Otherwise, we wouldn't be talking about them getting mechanical support. So they're all New York Heart Association Class 4, and most of the patients are typically on inotropic support at the time of implant. And when you look at them about 6 months later, about 80% of the patients are either Class 1 or Class 2. So they have a fairly significant functional benefit. When you look at sort of other measures of performance, the 6-minute walk, you can see that patients start with pretty poor 6-minute walks and improve over time, but their 6-minute walk distances still aren't fantastic. So they're still in the sort of 300 to 400 meter range. They also improve other things like quality of life, and it depends on sort of your measure of quality of life. The Kansas City Cardiomyopathy assessment of quality of life is more of a heart failure specific quality of life measure. The EQ5D is a more general global sense of quality of life. As scores get higher with the KCCQ, that means better quality of life. As scores get lower with the EQ5D, that's also better quality of life. And you can see that patients have a pretty substantial benefit even as soon as 3 months, and it lasts out to 6 months. And when we've looked at patients over longer periods of time, their quality of life tends to stay stable over the first, certainly, few years of their implant. But one of the things we've struggled with a little bit is that their quality of life, although it improves with all these devices, and this is sort of a cross-section of many trials over the course of the past 20 years with the most recent trials on the top of the most recent devices, you can see the sort of peak quality of life sort of maxes out and when we look at a variety of different measures. So although the devices have gotten better and their quality of life is better, we haven't made a ton of improvement in their overall maximal quality of life. And some of this may have to do with exercise tolerance, and it bears importance when you're thinking about cardiac rehab. As I mentioned before, these devices are set at a particular speed, and the speed doesn't change over time. However, when the device can accommodate more blood flow if it's getting more blood flow from the right side of the heart. So even at a fixed speed, it can augment cardiac output a little bit. The other thing that can happen with exercise, depending on the sort of residual function of the native heart, is the native heart can contribute to cardiac output as well. In this little cartoon, you can see the LVAD flow as measured by the LVAD with different states of exercise from baseline to peak exercise. And you can see it goes from 3.7 liters a minute to 4.7 liters a minute, again at the same RPM. So the RPM is not changing, but the pump can accommodate and can respond to preload a little bit. But the cardiac output as measured by a right heart cath goes from around 5 liters a minute to almost 10 liters a minute. And that's not all the pump. Some of that is the native heart. And again, this varies from person to person based upon how much residual function they have. But the reason why it's important when we're thinking about exercising these patients is this. So if you look at the left-sided filling pressures of the heart, so the pressures that we sort of infer that are in the left ventricle at the time of exercise, you can see when they start out, the pump does a pretty good job of decompressing the left heart. The wedge pressure is only 11, but as they exercise, the wedge pressure goes up. And the less your native heart is able to contribute to cardiac output, the more your left-sided filling pressures will go up. And when you exercise, you get to the point where your pump can't accommodate much more, and so you start to have dyspnea related to elevated filling pressures. And you can see these elevated filling pressures are also reflected in the pulmonary artery pressure and the right atrial pressure. And the other thing that can limit exercise, and I won't get into the gory details of pressure volume loops with this group, but you can see a baseline, that sort of squat square is the pressure volume loop of the right ventricle. And you can see when you exercise, and early in exercise, labeled as exercise 1 here, the RV can actually squeeze a little bit more, but it reaches kind of its maximum level pretty quickly. So these patients, when they're exercising on a VAD, may be limited by their VAD speed itself, and they may be limited by their right ventricle too. And so various patients have varying degrees of right ventricular dysfunction. So there's a lot of things that may contribute to the inability to exercise at peak in patients with mechanical circulatory support that are a little different from patients with heart failure alone or patients post-transplant. The other thing is, with a lot of our patients and even the transplant patients, is they're not only deconditioned, but they're frail. They have decreased muscle mass, they have low metabolic rates, they're still in an inflammatory state despite the fact that they're adequately supported with their VADs. So there's a lot of things contributing to their inability to exercise that we also need to address in addition to improving their conditioning. When you look at cardiac rehab, I think everybody's pretty familiar with it. The sort of eligibility for cardiac rehab varies across the country, maybe better on the East Coast than here on the West Coast. But when you sort of look at the eligibility for various cardiac disease states, from stable angina to heart failure to patients who have biventricular pacing to LVADs, you can see the LVADs, the CR eligible population is pretty small, but there's not that many patients getting it. Interestingly, when you look at the percentage of the patients with those particular things that are actually participating in cardiac rehab, is actually really high in LVADs, almost 50%, and definitely outpaces a lot of the other disease states that we've been talking about today. So I think everybody recognizes the importance of it, but it is sort of a small specialized patient population. So what do we know about it? Well, this is looking at cumulative hospitalizations in patients who didn't get cardiac rehab after LVAD in the blue versus those who did in the red. And you can see when sort of looking at the sort of large national database of patients who are Medicare beneficiaries. This isn't everybody who gets an LVAD, but many of the patients who get an LVAD. There is some benefit in terms of decreasing repeated hospitalizations after your implant. What about other sort of hard endpoints? Well, when you look at different predictors of 1-year mortality in the same group of patients, we know that participation in cardiac rehab basically halves your 1-year mortality risk. And when you look at other things like the cumulative hospitalizations that I just showed you, again, cardiac rehab participation decreases your risk of cumulative hospitalizations. So it has impacts beyond just how the patients are feeling. The problem is there's not a lot of good randomized controls or studies of patients who get cardiac rehab after an LVAD. The studies kind of typically look like this, a handful of patients, and when you look at things like peak VO2, it tends to maybe get a little bit better in the patients who undergo cardiac rehab versus usual care. There was other studies that kind of looked at different things as like surrogate endpoints. When you look at leg strength, you can see that with cardiac rehab, the leg strength tends to get a little bit better compared to usual care. Again, very small numbers. And kind of reflecting some of the other data I've showed you, patients who undergo cardiac rehab tend to have a better quality of life as measured by the KCCQ, in this case, a heart failure specific measure of quality of life. When you look at sort of the meta-analysis there's really only sort of a few small trials, but they all tend to show benefit to cardiac rehab after mechanical circulatory support. The most recent trials that I could find kind of mirror these findings. So those trials are maybe a little bit old with maybe devices that we don't really use anymore, and their patients are managed in ways that we maybe don't quite manage them today. This is the most recent trial of cardiac rehab patients in patients who get current generation devices, and even these devices aren't necessarily current generation, but they are managed the way we do now. It's a relatively modern, quote unquote, study of patients who have mechanical support and get cardiac rehab. And it shows a lot of the same thing in terms of what we've seen with some of the other trials. There may be some increments at VO2, maybe not at peak, but at the peak ventilatory threshold. But this trial also shows something that Liz sort of pointed out with the heart transplant patients. We don't necessarily look at all the same parameters when we're assessing exercise in patients with mechanical circulatory support. You can see on the left-hand side, the predicted maximal heart rate is in the gray bar, and you can see the resting heart rate in sort of the light blue. But even when patients are at peak exercise, they're really nowhere near their predicted maximal heart rate. So there's a number of things that may limit our ability to exercise these patients, and may also limit our ability, or sort of we have to change our thinking about how to assess exercise in these patients. There's not really a uniformly accepted way to think about cardiac rehab or rehab in general in the patients who've had mechanical circulatory support. But I think this is a really good summary from the Europeans from just a couple of years ago. And I think this reflects kind of where we are now, even though we may not necessarily have a big standardized agreement on what this pathway should look like. I think that this pathway shows the early mobilization, sort of right after patients are implanted, in terms of doing things in the hospital, even when they're in the ICU, to kind of get them moving and get them stronger again. But I think the focus of today's conference is more on this second section in terms of looking at what we do with them over the long term. So again, there's no standardized way we think about exercising these patients, but there's a lot of things that we need to kind of keep in mind in terms of not only the patients themselves, but their equipment and their drive lines, and keeping them safe and making sure that the staff there is adequately trained, and sort of what we look at as clinical stability, and how we measure blood pressure, and maybe the inability to assess pulse unless you have someone hooked up to an EKG monitor. So there's a lot of things to kind of keep in mind when you're exercising them, but even once you've kept those in mind, it's a lot like exercise programs in patients who don't have mechanical circulatory support. The slide is a little bit busy, and I just kind of put this up there because it's part of the guidelines from Europe. But there's kind of a nice sort of things to think about when you're assessing patients with mechanical circulatory support and you're exercising them. So like I said, a lot of what we will be doing is what we normally do in our heart failure patients. But there's other things to think about in terms of what the patients need, and some of the things you need to provide safe exercise for these patients, and to give them sort of put them on a maximal pathway to success over time. So in conclusion, VADs are as common as heart transplants, but they're different, and so we need to kind of keep that in mind when we exercise them. They do have unique physiology, and they do have some unique needs, but nothing that most cardiac rehab centers can't handle. I think cardiac rehab is underutilized in this population, but it certainly seems to impact mortality, hospitalizations, and even quality of life. And we've seen benefits in trials in things like some aspects of their exercise tolerance, but the trials are really few in number and they have very small enrollments. We have to take all that with a little bit of a grain of salt. And I think the best outcomes for our patients require, again, some modifications of typical cardiac rehab protocols, but nothing that's too big of a lift for most programs to be able to successfully get patients through a good cardiac rehab protocol, even if they have mechanical circulatory support. And with that, I'm happy to take any questions.
Hi, Dr. Thunberg. I think that in the interest of time, I'm just looking at the Q&A. Perhaps you could just keep an eye on that for a couple minutes after the talk and answer. The one question I have for you, and again, thank you both to you and Elizabeth for a very, very informative talk, is, do you feel like the VAD patients get the same kind of secondary benefits, including beyond just the exercise training, some of the other things we've talked about with like some of the mental health support, the dietary support? Do you think they have the same amount to gain?
I suspect they do. We don't have a ton of evidence to say that's the case. I'm not sure why it wouldn't necessarily be the case. I mean, we extrapolate a lot from heart failure, but I suspect a lot of that is the same. We see a little bit with some of these trials in terms of benefits and things like assessments of quality of life, but I don't have a ton of data to back that up.
And then there's one question in the chat. What devices would we need for LVAD patients regarding getting heart rate and blood pressure while exercising? I think the bigger question you might want to answer there too is that, how do you define the metrics for kind of their exercise goals? Do you put them on treadmills ahead of time, or what do you do?
I mean, personally, we work with a lot of our physical therapists and our exercise partners to sort of give us a sense of sort of where they are. I mean, it's a lot like a patient who comes out post-op from a CABG, right? So some of them are weaker and require more basic rehab first before they're stable enough for something like cardiac rehab. And I would say the same basic things that they need 6 weeks for their sternum to heal and some other things before they're really ready to get up on a treadmill. But many of these patients exercise on a treadmill or a bike regularly at home, so there's no reason they can't start to have similar sorts of goals, or at least similar sorts of programs as someone with heart failure or heart transplant.
Thank you. And so I will go ahead and, instead of taking we're going to take just a couple minutes stretch break, because I think it will be good to stretch our legs and have everyone stand up. So it's 1:41 my time. We'll do like a 3-minute stand up restroom break, and then we'll come back and start with Dr. Burton's talk at 1:44. Thank you.
My name is Eldrin Lewis, and I'm the Chief of Cardiology for Cardiovascular Medicine. The Cardiovascular Medicine division at Stanford is tremendous. Not only can we manage the standard cardiovascular disease, we can actually manage mitral valve disease, aortic valve disease, and even tricuspid valve disease percutaneously. We have world-renowned cardiologists, cardiac surgeons, as well as staff, all who work together as a team so that we can provide cutting-edge, innovative cardiovascular interventions. We can take a patient's underlying genetic risk, understand the environment in which they exist, and then apply that to maximize outcomes. If you were to refer one of your patients to Stanford Health, you should expect that we're going to work together with you to maximize the health care of that patient. Your patients will have access not only to just what cardiovascular medicine can provide, but what all of Stanford Health can provide. And we have a lot of teams outside of the cardiovascular division to provide comprehensive care for patients who may have more than one disease. We want to make sure that we're giving your patient back to you so that they can continue to receive the outstanding care that you've been delivering longitudinally. We want to use technologies so that we can communicate with you about all of the things that happened to improve the health of your patient. You don't necessarily have to have your patient come all the way here, but we can use virtual visits or even communications with you to try to answer a specific question. So we are poised to apply our research knowledge, our clinical expertise, and our innovation and technology to improve the patient care and to improve outcomes for all patients who come and see us.
The Stanford CVH Flare app is a phone app for clinicians that helps you curbside the right Stanford cardiovascular health specialist via HIPAA-secure text. There's also cell phone number sharing, and you can refer patients through the app HIPAA compliantly when needed. To give you a quick demo of the app, I'll click on its icon here on my home screen. I'll navigate into the right specialty to find Dr. Perino. There he is. And if I click on him, I'm able to click Refer to this doctor. I can use this to refer, but right now I'm just going to ask a clinical question about a patient that I have. So I type in my question, patient presents with X, and should I do A or B? This is very quick, just like sending any kind of text message. You don't need to fill in any of the other fields, just hit send, and that will give Dr. Perino a notification that you've sent a message. And as you see, you can tap on that referral you sent, no patient information has been provided yet, and you and Dr. Perino can have a secure communication. You can tap on his avatar to get his contact, where you can favorite him onto your favorites list if you need easy access in the future. You also have his contact information should you want to call or email him. So you have all that at your fingertips. You can also, like I said before, click Refer to this doctor to send a referral. And in that case, you will want to fill in all of these fields to include the patient information. To download the Stanford CVH Flare, please use the link that we emailed to you at 10 a.m. this morning, or search for Stanford CVH Flare in the App Store. If you have any questions, please reach out toll-free anytime at this number, or email stanford.support@flarehealth.app. Thank you.
Okay, everybody. Hopefully you got a chance to stretch. Welcome back. We're going to start our next panel talk with a recorded session from Dr. Elon Burton, as well as nurse practitioner Martina Spate. Dr. Burton is an assistant professor in the Department of Cardiothoracic Surgery and a board-certified cardiothoracic surgeon. She has completed specialized training in robotic techniques for minimally invasive CABG. This procedure enables access to the heart with smaller incisions than traditional coronary artery bypass procedures. And in addition to her clinical practice, Dr. Burton has conducted research on health disparities in cardiovascular disease, diversity in radiology and molecular imaging, and a variety of other topics. She has volunteered her time and expertise as a high school medical student club faculty mentor, as well as a community health nutrition and interventionalist. So with that, I will ask Jessie to go ahead and start her video. And then after that, she will be Martina Spate will speak. She has been a longtime nurse practitioner in our structural heart program. In her role as nurse practitioner, she has become a valuable clinical expert in the care and management of patients undergoing transcatheter therapies and valve disease. Her passion is about leading efforts that improve program outcomes, efficiencies, and patient experiences. And they will both kind of talk about exercise after open and transcatheter valve treatments.
Hello, everyone. My name is Dr. Elon Burton. I hope everyone has enjoyed the symposium thus far. I would like to thank the organizers for putting together a great program. Unfortunately, I had a conflict in my schedule and I'm unable to attend in person, but please feel free to contact me with any questions or comments. Today, I'm presenting the topic of cardiac rehabilitation after open heart surgery. I have no funding or conflicts of interest to disclose. My objectives today are to identify various surgical approaches of heart valve and coronary artery surgery, explain how surgical approach influences rehabilitation treatment plan, and to recognize the importance of post-cardiac surgery rehabilitation. Traditional cardiac surgery is conducted through a median sternotomy. This requires placing a retractor in between the edges of the sternum and retracting laterally. If performing a CABG using the internal mammary artery, an additional retractor is used to lift the chest wall superiorly and sometimes additionally laterally. Conventional cardiac surgery has been performed with the aid of cardiopulmonary bypass or on pump. This may also require applying a clamp to the aorta as well to arrest the heart so that surgery can be carried out while the heart is not in motion. However, cardiopulmonary bypass has side effects, such as peripheral hypoperfusion and increased levels of metabolism and tissue perfusion markers. These metabolic changes may influence the patient's postoperative rehab course. This will be discussed later in the presentation. Cardiac surgery can also be done without cardiopulmonary bypass or off pump. With off pump surgery, there are less metabolic derangements. Patients tend to have better post-op renal function. Typically, there is not substantial ischemic time, thus there is reduced myocardial injury. And because the patient's blood is not in constant interface with the cardiopulmonary bypass tubing and circuit, there is lower activation of inflammatory mediators. Moving to minimally invasive cardiac surgery, there are two typical incisions used for valves for minimally invasive cardiac surgery. One is called the mini sternotomy, and the other is a thoracotomy incision. The mini sternotomy is typically used for aortic valve surgery, but can also be used for surgery on the ascending aorta and sometimes mitral valve surgery. For thoracotomies, this requires one lung ventilation. A right thoracotomy is typically used to approach aortic valve, tricuspid valve, or mitral valve. For left thoracotomies, this is typically used for pulmonary valves or for mitral valves. Minimally invasive approaches for valves still requires cardiopulmonary bypass, so additional incisions may be necessary for cannulation. Cannulation strategies include either direct cannulation through either the mini sternotomy or thoracotomy incision, or you can use femoral cannulation, which will require a groin incision, axillary cannulation, which is typically used for the aortic cannula only, or a combination of these strategies, including use of the internal jugular vein. For minimally invasive coronary artery bypass surgery, these surgeries are typically done off pump. The IMA dissection and bypass graft is done through the same thoracotomy incision, which consists of a left anterior thoracotomy. As you can see in these photos, the photo on the right shows the IMA retractor, which you're still retracting the sternum superiorly and actual laterally. And the photo on the left shows the stabilizer in place for the off-pump bypass graft. A subset of minimally invasive cardiac surgery is robot-assisted surgery. This is very similar to minimally invasive surgery in that there is a thoracotomy incision with the addition of ports for robotic arm insertion. Port placement is based on the type of surgery to be completed, either valve surgery, typically mitral or tricuspid, or for IMA mobilization. As mentioned previously, the robotic valve, just like a minimally invasive valve, robotic valve also requires bypass, where typically coronary surgery is off pump. I am sure many of my colleagues have touched on the information in the following slides, but I want to start with a brief overview of cardiac rehab. There is a misconception that cardiac rehab is only focused on exercise and building strength after heart surgery. However, cardiac rehab focuses on optimization of all aspects of cardiac health. This requires a holistic three-pronged approach. One, exercise counseling and training, which is what most people think about traditionally when cardiac rehab is mentioned. However, there's also an education and counseling component to cardiac rehab. Education concentrates on heart-healthy living and mitigating risk factors, such as guidance on smoking cessation and teachings on how to follow a healthy heart diet. Counseling helps patients develop positive coping mechanisms as well as healthy strategies to help reduce stress. As studies have found, constant high stress levels can be detrimental to heart health. Though this presentation is focused on post-open cardiac surgery, I wanted to share other indications for cardiac rehabilitation, as this will be relevant later in the presentation. Additionally, participating in these programs pre-surgery can help with post-operative recovery. As previously stated, cardiac rehab aims to improve all aspects of cardiac health. Some benefits include improved exercise capacity, enhanced quality of life, improved psychological status, and building healthy habits. Most importantly, however, patients that complete cardiac rehab programs have a reduction of 5-year mortality post-MI or post-heart surgery by about 35%. Cardiac rehab programs can be divided into 3 phases. The first phase is usually as an inpatient setting, where they're assessing the physical ability of patients and their motivation to complete a program. The second phase starts as an outpatient, and this phase is more rigorous and is used to promote independence. The third phase builds on the second phase and centers on maintaining what was learned in phase 2. Here is an example of a cardiac rehab protocol. The take home here from this slide is that rehab participation does require dedication and commitment from the patient to complete the program, as it can be very time intensive. Some items to consider from a surgical perspective when beginning a cardiac rehab program. As previously mentioned, retraction on the sternum happens in different directions in order to complete the open heart surgery. This can cause stretch on the brachial plexus, musculoskeletal pain in shoulders back, and of course in the chest. And some patients with particularly brittle skeletal structures, they can also suffer fractures of the costochondral cartilage. Thus, we usually say sternotomy precautions are about 6 to 8 weeks. I also tell patients to treat their sternum as if it's a broken bone. So just as if you were to break your leg, you wouldn't go run a marathon a week after breaking your leg. Thus, I tell patients to lift no more than 10 pounds during this recovery phase. Though some healthcare providers may be moving away from weight restrictions and letting the patient's pain be a guide to their activity, I find patients have different pain tolerance, and some patients may overdo it. As an example, I did have a patient who was an avid motorcyclist, and he dropped his bike, and when he went to pick it up, he felt pops throughout his chest, and upon examination, he had sternal instability, and this required repeat surgical closure, and this was about 3 to 4 weeks after his initial surgery. So I found setting a weight limit until the patient returns for a post-op visit to check stability of the sternum is the safest way to ensure patients are taking adequate precautions to allow the sternum to heal. I also get a fair number of questions about driving. Many of the patients are taking strong medications immediately post-op, and it's unsafe for them to drive. Additionally, if one should unfortunately have a car accident, the impact of hitting an airbag or the steering wheel could fracture the sternum in the post-op period. Here are examples of activity modifications post-sternotomy in that first 6 to 8 weeks. The main takeaway here is to move as if you were in a tube. As opposed to sternotomy procedures with minimally invasive procedures and robotic procedures, there's a little more leeway in activity and in general, less time to return to full activity. Again, the weight restriction is more of a reminder to not overdo it while the incision heals. And there's a little bit more emphasis on using your incentive spirometer. Though this is true for sternotomy patients as well, with the thoracotomy incisions, they're a little bit more painful and they could have rib fractures. So it makes it very important for patients to continue their pulmonary exercises because they're prone to pneumonia. Now, I wanted to examine the differences between the different surgical approaches and progression and how this may affect progression in cardiac rehab. Nakajima conducted a study that examined post-op physical activity between patients that had traditional cardiac surgery and those that had minimally invasive. Both groups had similar pre-op physical activity levels, but what they found is that in the minimally invasive group, they had significantly higher physical activity level post-op, and the rate of change in the amount of physical activity was significantly higher in the minimally invasive surgery group. This study supports that minimally invasive approaches are associated with improvement in postoperative physical activity over the median sternotomy. I mentioned previously that cardiopulmonary bypass could also influence patient performance in cardiac rehab due to metabolic changes. One study examined the effect of cardiopulmonary bypass on enhancement of metabolic equivalence before and after participation in a cardiac rehab program. These pre and post-op cardiac rehab, the metabolic equivalent values in the off-pump surgery group was higher versus the on-pump surgery group. These findings may be due to the different metabolic requirements of on-pump versus off-pump surgery. We have discussed the benefits of importance of cardiac rehab, but what are some of the barriers to patient participation? So one barrier is patient education. Some patients have found it difficult to obtain detailed information about cardiac rehab. So the University of Washington developed a patient information handout that's easily accessible via online. This handout describes the benefits of cardiac rehab and outlines what physical activities the patients are expected to perform both in hospital and at home after discharge. Additionally, another barrier to participation in cardiac rehab is physician referral. What some studies have shown are that doctors may be less likely to suggest rehabilitation to women, and that women, and especially women of color, are less likely than men to start or complete a cardiac rehab program. A study conducted by Dunlay found that a patient that has a cardiologist as their main healthcare provider are more likely to get referred to cardiac rehab after an event. The same study also found that patients referred to cardiac rehab tended to be younger than those who were not referred. Also, patients that had a revascularization procedure such as a stent or a CABG, coronary artery bypass grafting, had a previous MI or had received cardiac rehab consult while as an inpatient were more likely to be referred for a cardiac rehab program. Other considerations that may affect barriers to participation include, from the same study that Dunlay performed, that they found that males with higher BMIs are less likely to participate in cardiac rehab. And in addition to physician referral barriers, individuals of older age, especially those with other medical conditions like arthritis, may think that they are unable to participate in these programs due to their age, or they feel that the exercise would be too difficult for them to complete. Another barrier is the time commitment necessary. The programs are multiple sessions per week, and these last for several months. This is also a time commitment for caretakers. Most patients will be unable to drive to these appointments and will have to rely on caretakers for transportation. So how can we improve patient participation? So one is educate physicians. Previously, I discussed indications for cardiac rehab, and though this presentation is focused on post-op rehab, being aggressive in enrolling patients after a cardiac event, if cleared by their cardiologist, even for a short period of time prior to surgery, can still be helpful in the post-operative recovery period. Educate patients on the importance of participating in a cardiac rehab program and reinforce that all patients can participate regardless of their perceived limitations. Additionally, early enrollment is key. Arranging cardiac rehab prior to discharge increases the likelihood of patient participation. In the study previously mentioned by Dunlay, they had inpatient consults, and this consisted of the rehab team discussing the details of cardiac rehab and answering any questions that the patient may have about the program and the process. The inpatient counseling session was then concluded with scheduling the post-discharge cardiac rehab appointment. So in conclusion, when comparing traditional and minimally invasive surgical approaches, minimally invasive approaches usually have a faster recovery due to less physical limitations. And when comparing on-pump versus off-pump, on-pump surgeries have more metabolic derangements and can affect patient stamina when participating in rehab. Thus, patients with traditional or on-pump surgery may need a longer cardiac rehab program versus those who have undergone minimally invasive or off-pump surgery. There are also multiple benefits of cardiac rehab outside of improving physical strength, such as counseling and teaching healthy lifestyle habits that can help mitigate cardiac risk factors. Suggest referring patients early in the process, and reinforcing the importance of rehab to improve compliance. And finally, make sure that the PCP is in the loop about what should be happening post-surgery. And this can also serve as an added resource to reinforce the benefits of cardiac rehab. This concludes my presentation. Thank you for your attention, and I hope you enjoy the rest of the session and symposium. Please feel free to contact me with any questions or comments.
Good afternoon. Hopefully you can see me okay. My name is Martina Spate. Thank you, Dr. Kandawal, for the earlier introduction, and thank you to you also, Jonathan and Jesse, for including me in this today's awesome agenda. So thank you very much for that.
Martina, you may have to switch your view to presenter mode because we can see your screen. Yeah.
Not sure how to do that.
If you'd like, I think Jesse, do you have her slides? You can always.
Or is there a way to?
Yes, I have your slides. Let me go ahead and pull them up.
Let's see that. Oh, you know what? Let me try something else. How about this? Is that better?
Yes.
Okay, here we go. Okay, sorry about that. I picked the wrong screen to share. Again, my name is Martina Spate. I'm delighted to be here today to talk about transcatheter heart valve therapies and participation in cardiac rehab in this patient population. These are my disclosures, of which there will be no conflict in what I am telling you today. And my objectives today are really to share with you and help you appreciate the current, rapidly changing transcatheter heart valve landscape, and to talk about the utilization of cardiac rehab in this very much emerging population. And I'd also like to talk about the challenges, the considerations, and really the opportunities for cardiac rehab in this patient population. So I'll start by talking about the aortic valve in this patient population. Severe aortic stenosis is the most common valvular heart pathology in adults. And the most advanced transcatheter therapy for the treatment of aortic valve disease is TAVR, or transcatheter aortic valve replacement, which is a catheter-based delivery of a replacement valve within a diseased valve, which really ultimately, creates the avoidance of sternotomy, like was described in the previous talk, and the avoidance of cardiopulmonary bypass. Many still consider TAVR to be a new treatment, but the first in man was actually done exactly 20 years ago by Alain Cribier in France. However, it's really in the past 10 to 12 years that the completion of robust randomized trials and FDA approvals that we've brought about these rapid changes in the indications and use of TAVR. TAVR is approved for the treatment of severe symptomatic aortic stenosis in high, intermediate, as well as low risk patient populations. And nearly 500,000 TAVR procedures have been performed worldwide, with 900 centers here in the US alone performing TAVR procedures. So ultimately, TAVR has become a valid and viable alternative to surgical aortic valve replacement, with trial data demonstrating actually superiority over SAVR in low risk populations, looking at the newest generation devices. There's also been a focus on less invasive catheter-based treatments for the treatment of severe mitral regurgitation. When left untreated, mitral regurgitation has a mortality rate up to 50%, much like aortic stenosis. Transcatheter edge-to-edge repair, or TEER, of the mitral valve is essentially a clipping procedure to reduce severe MR. It doesn't necessarily mitigate the disease in its entirety. And it's important to consider the etiologic source of the MR in these patients, because it will be either primary or degenerative, or secondary functional MR as a result of ventricular dysfunction. And knowing this etiology has implications on patients' recovery and perhaps their ability to exercise. So those with secondary MR have multifaceted heart failure, and their recovery and their benefits may look completely different than those whose source of symptoms come from a mechanical or degenerative source, like a prolapsed leaflet or a torn cord. And there are many creative ways to actually replace the mitral valve as well. with catheter-based techniques for the treatment of MR and or mitral stenosis. And we can actually implant valves within failing bioprosthetic mitral valves, surgical valves within surgical rings, and in certain cases, we can implant transcatheter heart valves in a patient's native mitral annular calcification. So it's also important to note that the mitral valve is a complex apparatus, and interventions within it are far more complex than performing interventions within an aortic valve that essentially has 3 equal-sized leaflets and does not have cords and tendons attached to it. So certainly want to make a point to appreciate that fact. And there's also been further device innovation to treat tricuspid valve disease. And it's similar to those therapies in the mitral valve, but they do remain investigational at this juncture, it should be said. And we also look at clipping procedures by tier or also replacement with a prosthesis within a native tricuspid valve. And I feel that this is a very promising treatment space, but also has its challenges given that the often, advanced degree of heart failure that these patients present with, as well as sometimes the advanced liver failure and, other medical comorbidities these patients present with. But hopefully with earlier referrals and increased access to clinical trials, we can really start to help what has once been considered the forgotten valve, the tricuspid valve. So I want to take a moment to highlight the area with the greatest volume of transcatheter heart valve therapies, and that is certainly the TAVR space, the treatment of patients of their severe aortic stenosis with TAVR. And when we talk about cardiac rehab use in this population, TAVR is really the best example, although the mitral valve population are certainly also cardiac rehab eligible. But I think it's important for you to know, if you don't know, that Medicare requires all hospital centers performing TAVR, again, about 900 here in the US, as well as hospitals performing transcatheter mitral interventions, of which there are less than TAVR centers. Nonetheless, they're required to participate in a national registry in order to reimbursement of the procedure. So what I'd like to share with you is a little bit of that TVT registry data that was published in 2020, data that was inclusive up to 2019, to really help you get a better understanding of this rapidly changing patient population in this rapidly changing landscape of catheter-based therapy. So isolated TAVRs exceeded the number of isolated surgical AVRs in 2015, represented by the arrow in number 1 on your screen. And it exceeded all SAVRs, so any sort of concomitant surgical aortic valve procedure, by 2019. So greater than 95% of patients are treated with a transfemoral approach to their transcatheter aortic valve versus an alternative access approach, which sometimes has implications on a longer recovery pathway. So over time, TAVR outcomes are associated with reduced mortality. They have less complications, like maybe they were historically noted for, like stroke or vascular injuries. So yes, a lot of wins in the TAVR space, but certainly not without its challenges. And we're constantly learning about ways that we can better these treatment options and better identify patients that will benefit. When we talk about the risk profiles of our patients, we're actually talking about their 30-day risk of mortality by using the STS, or Society of Thoracic Surgery score. And the average STS score has reduced over the last decade as we've expanded the indications of TAVR to include lower risk patients. And this means that patients are presenting with less comorbidities and less heart failure symptoms. There's actually a reduction in the heart failure classification at the point of initial referral and treatment. And over here, I just kind of wanted to share and show you this red bar here represents the growing number of what we call valve-in-valve transcatheter aortic valve replacement, which essentially offers a redo AVR procedure for failing bioprosthetic valves using the same catheter-based techniques and avoiding reduced anatomies. Less complications, better outcomes, and lower risk. Also, with less comorbid patients, has resulted in decreased length of stay in the hospital for our patients, with increasing discharge dispositions to home environments versus extended or nursing care homes. And importantly, the mean age of our patients has actually reduced significantly over the past 10 years. And that does not mean that the octo and nonagenarians have gone away. They're still there, but they're just among this kind of newer, quote unquote, younger generation of patients. So I tell you about all of these features really to help you understand the gamut of patients that are moving through our clinics and our hospital systems, and hopefully potentially entering into your cardiac rehab programs as well. I also want to mention and kind of highlight our ability to complete really comprehensive risk assessments in our transcatheter heart valve patients. And it really allows us to have a deep appreciation of the comorbidities that they present with, and better understand the patient population, that better understand how that will impact their recovery and outcomes. And not only do we consider subjective measures of frailty in our patients, but we actually complete objective measures of frailty, like grip strength, walk speed. We measure serum albumin as a marker of their nutrition, and we get a complete assessment of their ability to independently, complete their ADL. So it's also important that you know that we also consider patient-stated goals in our consideration of TAVR or mitral clip for treatment of their disease. So the fact that we're gathering this information, it may actually provide a unique opportunity, I feel, to help us customize and individualize cardiac rehab and exercise programs. But I think we just need a better conduit to be able to share that information and be consistent with the way that a hospital center is doing that. This slide demonstrates the benefits of cardiac rehab on disease-specific therapies. And this area up here with the green arrow highlighting illness really kind of appears as though it aligns kind of time-wise with the initial therapy. But I think, given that heart valve patients are on the spectrum of heart failure, or that they have a long latent period, or maybe there's a delay in the timing by which they're referred to a heart valve center, I think it's just important to appreciate that point of illness to the point of therapy could be a short period of time or a long period of time. And of course, that's going to impact their ability to benefit from cardiac rehab. But hopefully, cardiac rehab in this patient population, like so many other patient populations, will hopefully improve exercise capacity, improve their quality of life, which we do measure as part of our registry requirements. We hope that it would reduce hospitalizations, increase their independence, and of course, decrease depression in this group. TAVR patients had historically low rates of cardiac rehab participation, unfortunately, especially when compared with surgical aortic valve replacements. Fortunately, participation in both groups continues to grow over time, but the difference between the two groups is essentially unchanged, as you can see here, with SAVR represented with the red line and TAVR represented in the yellow line, and the blue line is actually the two groups combined. This trend really highlights this ongoing disparity that other speakers today have also highlighted, that participation in cardiac rehab, amongst patients receiving percutaneous interventions like PCI or like TAVR is less than those receiving, more surgically or more invasive treatments of their coronary disease or their valve with open heart surgery. This highlights the need to really, report various procedure-specific rates of cardiac rehab participation separately, and hopefully that will improve participation and also help us better understand how those patients are benefit and customizing programs to the two different groups. The differences across the treatment strategies may be due to a variety of reasons. I think it's assumed that maybe the efficacy of cardiac rehab in this patient population is unknown. So perhaps that's impacting the delay or the avoidance of referral to cardiac rehab at all. And as was discussed earlier in some of the other patient populations, perhaps it's assumed that so many of these TAVR patients are frail or infirmed or disabled or socially isolated, and that cardiac rehab is not suitable, when in fact the opposite is probably true. So these are the exact reasons that they should be referred to cardiac rehab. But I kind of wanted to take a little moment to talk about this, again, this emerging population and this change in population, and kind of share with you kind of some anecdotal experience from my own clinic, where I see up to 1,000 patients a year that are in varying stages of their post transcatheter recovery. And these are considerations that really may impact cardiac rehab enrollment and may also be perceived as barriers to enrollment, and that we need to better understand. TAVR patients, and to a lesser degree mitral patients, have less disruption of their baseline functioning because our procedures are inherently less invasive. So it's easier to return to a round of golf when you don't have a sternotomy procedure. And in this newer, quote, younger TAVR population, there's a desire to resume baseline activity sooner, because again, there's no sternal percussions, and also because perhaps those activities really aren't that far in their rear view mirror, and that the decline in their functionality may not be so significant. And to continue the golf example, patients that may have reduced their ability to play 18 holes of golf to 9 because of their aortic stenosis will find it easier to return to 18 holes of golf, and so often this is the case with this often motivated population. So I just kind of want to highlight that this shift is happening, and we're seeing this in our clinics. And again, like Dr. Tremmel had said earlier, in her SCAD patients, they are already baseline fit, and I'm observing that in my patients, that they think that it's unnecessary and they're not clear about what the benefit might be for them. Also, there's less in-hospital deconditioning in our transcatheter heart valve patients due to the fact that we've got this low length of stay. We use a lot of minimalist approaches like general anesthesia and ICU avoidance in our patients, reduce the use of invasive lines during procedures, and of course, we encourage early ambulation. There's also a decreased comorbidity burden with the new generation of patients in the low risk population. And this translates into faster recovery times and faster returns to baseline functioning. And for those with comorbidities like diabetes, there's these less invasive techniques cause less disruption in that disease. And so, as I mentioned earlier, we have great compliance and follow-up, mostly large in part due to our registry requirements. So I think it gives us a unique opportunity to encourage cardiac rehab if that has been missed at the discharge because of a patient, assuming that it's not required. It also gives us the ability to measure benefit to those that have completed a cardiac rehab as we see them at their 1-year visit. Digital health programs with wearables, I think, is also going to be of interest in this patient population to motivate those that are already on the move and living active lifestyles and maybe already wearing devices to support that. But it's also, a unique opportunity to reach those patients with limited access to in-person programs or transportation difficulties. This kind of isolation. So in conclusion, more data are needed to better understand the sustained mortality and morbidity benefit in this patient population. And again, as I stated, I think there's some unique opportunities to better understand the benefits, especially in the respective risk cohorts of these types of patients, and not just lumping them into all one group when we're looking at cardiac rehab in this patient population. Cardiac rehab is much more than physical exercise. The benefits go beyond physical recovery, as we've discussed so much today. Transcatheter heart valve patient presentation is emerging with rapid changes in device indications and technology. So I encourage you to watch the space and keep up with that. Cardiac rehab should be individualized with consideration of all baseline functional assessments. And we will always continue to encourage best practice models to optimize utilization in our patients. So thank you so much.
Martina, thank you
Yes, thank
very,
you.
very much. It was excellent. And Dr. Burton as well. I really want to thank you for your time.